Hey, I'm Chris Fanta. I'm a member of the Pulmonary and Critical Care Division here at the Brigham and Women's Hospital. I'm a professor of medicine at Harvard Medical School, and I direct the Partners Asthma Center. And today I wanted to spend time reviewing selected topics that aren't otherwise covered in our systematic review of pulmonary medicine. There are three that I wanted to highlight, and I have no financial conflicts of interest to disclose. The three topics that I thought would be worth discussing together today are hemoptysis, bronchiectasis, and bronchiolitis. And so let's just jump right in and touch upon these. Thinking about the patient with hemoptysis is, as you know, a broad differential diagnosis. We can think in terms of anatomy, bronchial bleeding, alveolar bleeding, pulmonary vascular bleeding, or in terms of categories of etiology such as neoplastic disease, infectious disease, immunologic diseases, cardiovascular disease, including pulmonary embolism, and inflammatory diseases, including chronic bronchitis or trauma. So they're listed here, and these are familiar, and it's a broad spectrum of potential etiologies. But in evaluating the patient, I think that the beginning, it starts with a chest x-ray. I think most patients with hemoptysis, even relatively minor hemoptysis, deserve a chest x-ray. And often the chest x-ray then guides further therapy depending on what is found. And I have four examples that help us illustrate this point of four abnormal x-rays. And they're fun to think about because each has a different process then for evaluation and management guided by the findings on x-ray. So let's look. First is a patient with 4 weeks of cough and discolored sputum intermittently mixed with blood. Patient has had fever and night sweats and significant weight loss. If you go get a chest x-ray, and it's quite striking, isn't it? It's very abnormal, particularly in the right upper lobe, although there's disease here in the left upper lobe and obscuring the heart border here in the right middle lobe. But let's focus on the right upper lobe. And as you look closely, I think you'll agree there's this circular opacity with a central lucency. There's a cavity up here. And extra credit if you identified this as the minor fissure that usually sits here, but has been pulled up in the characteristic pattern of right upper lobe volume loss or atelectasis in association with this cavity. And so this patient with fever and weight loss and hemoptysis and an upper lobe cavity, I think you're jumping towards a diagnosis as I am of tuberculosis. Could be fungal or some other abscess or occasionally a necrotizing cancer, but probably TB. So the workup guided by the findings on x-ray in this patient with hemoptysis, if they're in their office, put on a face mask. If they're in the hospital, they go into an isolation room, and we're going to work them up for pulmonary tuberculosis. And the treatment for hemoptysis is likely to be anti-tuberculous therapy with typically 3 to 4 drugs depending on resistance patterns in your region. Okay, check second x-ray of 4. This is a history of several days of hemoptysis with progressive shortness of breath and dark colored urine and a creatinine of 2.5 milligrams per cent. So you're starting to think pulmonary and renal disease. And here's another striking x-ray abnormality that's going to guide our evaluation of hemoptysis. This is classic ground glass opacity, isn't it? It's this sort of uniform haziness, filling of air spaces. Airways are patent, so you might see a little air bronchogram here. Alveolar filling, it's left more than right, but it's pretty much bilateral. And there's an extra credit finding of a little free air under the diaphragm here, which was probably post-op. So diffuse alveolar bleeding and renal dysfunction as the cause of hemoptysis, a fairly limited differential. You're thinking about pulmonary vasculitis or collagen vascular disease, We're going to do a serologic workup with ANCA and anti-GBM antibody, maybe ANA, and maybe we'll confirm the presence of blood in the alveoli with a BAL and expecting a bloody return, and maybe we'll need tissue biopsy, kidney or lung. And the treatment of this patient's hemoptysis is going to be high-dose systemic corticosteroids plus perhaps immunosuppressives or biologic therapy, maybe plasmapheresis treating a vasculitis. All right, third example, this is a heavy cigarette smoker with blood-streaked sputum, and he or she has had a chronic early morning cough. You notice clubbing. He or she has lost a significant amount of weight. You can see it in the way the skin hangs from their body. And you're thinking, well, let's look. Another quite dramatic x-ray. I'm sorry, these are underpenetrated copies. You can't make out the spine, but still it's enough to see this sort of fan-like appearance, dense here, maybe a big opacity here, and then the diaphragm way up. I think this is probably a diaphragm silhouette. So this is the pattern I wanted to highlight of left upper lobe collapse. When the right upper lobe loses volume, the minor fissure moves up. On the left, there's usually not a minor fissure, so the upper lobe falls forward and allows the lower lobe, still aerated, to fill up the apex here. And so this is all lower lobe. The left upper lobe has collapsed, probably from a big mass here centrally. And the diaphragm is pulled up either because of this volume loss or maybe even the phrenic nerve was involved. So you're thinking this is going to be lung cancer, a big mass, cigarette smoking, clubbing, maybe sputum cytology will be helpful. There's probably an endobronchial lesion. Let's look by fiber optic bronchoscopy. And treatment is going to be modern day treatment for lung cancer. Okay, last case. A patient with hemoptysis and pleuritic chest pain post-operatively. And here's the x-ray. Not much really, other than probably some blunting here of the left costophrenic angle. It would be clear on a lateral. The diaphragm on the left a little high compared to the right, so maybe there's some atelectasis behind the heart. And I point these out because, you're thinking pulmonary embolism. I'm thinking pulmonary embolism. And what are the plain film findings of pulmonary embolism? If there's anything, it'll be a small effusion and some atelectasis, and not the classic finding that we learned in medical school, Hampton's humps. Remember these, the pulmonary infarct, broad base along the pleura, a sort of rounded peak to this triangle, making it hump-like. Here's on this side and this side. I spent a lot of time finding this film. It's not common. And so what are we going to do to work up this patient's hemoptysis based on x-ray findings? Probably a CT angiogram if renal function allows, maybe a ventilation perfusion lung scan, and rarely do we still need conventional pulmonary angiograms. And paradoxically, to treat hemoptysis in this patient, anticoagulation. So we focused on the abnormal x-ray guiding our workup and treatment of hemoptysis. What if the x-ray is normal? And here's our question for the boards. What's the most common cause of recurrent or persistent hemoptysis? This is in a cigarette smoker where we did a normal chest x-ray. Here are our choices: lung cancer, chronic bronchitis, tuberculosis, aspiration, pulmonary embolism. And the correct answer, I'm clear in my mind, is chronic bronchitis. It's very common, chronic cigarette smoker, cough and phlegm. And if you look inside their airways, part of this chronic inflammation of the airways are prominent vasculature right here along the surface, and that these would let loose and bleed periodically. That wouldn't be surprising. So probably chronic bronchitis, but if you're worried about lung cancer, long-term cigarette smoker with hemoptysis, so am I. What's the chance that this patient has hidden lung cancer, hidden from X-ray, that you might discover by further evaluation, and it's not zero. There are multiple studies when people reported the frequency with which they found a diagnosis of lung cancer in those at risk for lung cancer with a normal chest X-ray. And now these are reported series, maybe inflated. They found on average, if we went through all these series, 7%. Maybe it's less than that. Maybe it's 3% or 5%, but it's a finite number. This patient could still have lung cancer, even with a normal X-ray. And at risk are those who are cigarette smokers, clearly those who are older. And I think we're going to evaluate that patient whose bleeding just wasn't one event, but has continued beyond just 1 week. And what's our evaluation to be? Typically, it's chest X-ray and fiber optic bronchoscopy, and we've thought of those as a synergistic evaluation. One more of the parenchyma, one more of the airways. The least we could do if in a resource poor area would be just keep checking the X-ray to make sure something doesn't appear. This is the person with the initial normal X-ray. What I wanted to say is that the modern chest CT imaging is so high resolution, so sophisticated, so enabling us to look at airways as well as lung parenchyma. Not perfect, but very good. That the vast majority of patients with hemoptysis will have a CAT scan and not need bronchoscopy. Here are several studies that looked at this question. What if the CAT scan in this patient with hemoptysis is normal? Not just the X-ray, but the CAT scan. And they didn't find any in several series abnormalities on bronchoscopy for a normal chest CAT scan. On the other hand, if there's a finding on CAT scan and it isn't obvious cancer, but there's some abnormality, we better look with the bronchoscopy, and then there is a finite finding. So most of the workup achieved with chest CT scanning. Let's take just a minute to think about massive hemoptysis. That's defined as more than 600 milliliters of blood in just 24 hours. That's a lot of blood. This is that plastic emesis basin overflowing with blood. It's 4 of these or 5 of these specimen cups filled to the top of blood. Very scary. And I remind you that that's our arbitrary definition of massive, but if someone has underlying lung disease and respiratory compromise, then even smaller amounts can be life-threatening because they have underlying disease. So thinking about the etiology of massive hemoptysis, I think top of the list nowadays is cancer of the lung cancers. In addition, tuberculosis, that cavity might let loose, the whole cavity might let loose and bleed. Bronchiectasis, lung abscess, mycetoma, and pulmonary vasculitis, they kind of head our list. Let's look at a mycetoma. It's just a striking image again. Here is a pre-existing cavity. Maybe this was old TB, maybe it was sarcoid or some other cavity. And within it, can you see this fungus? Well, here it's magnified and the so-called air crescent sign, a rim of air around the central ball that is the fungus and can lead to massive hemoptysis. We as medical physicians, what can we offer? We maintain adequate oxygenation and ventilation. If you know which side is bleeding, left or right lung, like our patient with the aspergilloma, put that side dependent with the goal of not spilling blood to the contralateral lung. So a bleeding side down. And then you're going to assemble a team to help you. This patient is life-threatening hemoptysis. The interventional pulmonologist maybe can come and with a bronchoscope put a balloon-tipped catheter to tamponade the bronchus that's bleeding. Maybe they can use localized coagulation techniques. You're going to call the interventional radiologist who can offer bronchial artery embolization, especially in those with bronchiectasis and big dilated bronchial arteries, most effective. Knowing that there is a small risk that as you try and put a clot into the bronchial artery as it comes off the aorta. It misses and goes into the adjacent spinal artery. You can cause spinal artery infarction and quadriplegia. That's a rare but frightening complication of the procedure. And you may also call your thoracic surgeon if there's focal disease like that aspergilloma and otherwise pretty good lung function. They might be able to resect the cause of massive hemoptysis. All right, good work. Now let's turn to the patient with other obstructive lung disease. You'll have a lecture on asthma, lecture on COPD, but what about these less frequently discussed airway diseases, chronic infection of the airways, bronchiectasis, and that would include cystic fibrosis, with the bronchiectasis being the pulmonary manifestation of cystic fibrosis, and small airway obstruction, bronchiolitis. Let's touch upon those. We won't talk about upper airway obstruction or central airway obstruction, such as you might encounter in someone with tracheobronchial malacia. I'd like to begin this discussion of bronchiectasis with a case that I saw many years ago. A woman referred for evaluation of quote unquote asthma is what was thought. Now, she had a 10-year history of wheeze, cough, and exertional dyspnea. Could have been asthma, although it started in midlife. Made worse by respiratory infections, cold air, and exercise. So she was already being treated back then with theophylline and inhaled albuterol. And when I saw her, her exam was full of these low-pitched wheezes called rhonchi, right? So not quite the same as asthma, but not the musical sounds, but low-pitched gurgling. You want to say cough, see if you can clear that secretion, and then listen again. And it was asymmetric, mainly on the right. And spirometry was a little funny. We talked about this as an obstructive disease, but sometimes there's restriction as seen due to obstruction of airway, complete obstruction of airways, and sometimes due to actual tissue damage and necrosis and loss of volume and atelectasis causing restriction. So bronchiectasis, obstructive, restrictive, or both on PFTs. And then, curiously, when she coughed phlegm, she had this bacteria Haemophilus growing on several occasions. That was another clue. Maybe this wasn't just asthma. And looking at her x-ray, although not striking, it's not normal either, and it's not typical asthma. There's increased opacity here above the minor fissure, and I think also here in the right. And a CAT scan will make the diagnosis. Here are multiple cuts, an old version of the CAT scan, but here in the right middle lobe, striking bronchiectasis, right, with these big dilated airways intermittently interspersed with mucus. So let's think about history that would make you think about bronchiectasis. Maybe it's daily cough and particularly discolored sputum production. Sputum on demand. Can you give me a sample of sputum? Oh, sure, no problem. Excuse me. There it is, yellow-green. That's probably bronchiectasis. Patients, as we talked about, have recurrent hemoptysis because of airway inflammation leading to superficial vascular bronchial vessel prominence. They may present with what looks as a recurrent bronchitis, frequent chest infections, or recurrent pneumonia, but when we look into it, it's always in that same area where the pre-existing bronchiectasis is, right lower lobe, right middle lobe, something like that. Or they may have a persistent finding every time they get a chest x-ray, like, oh, you have pneumonia, but it's not. It's the findings of the chronic bronchiectasis. And then in association, upper airway infection, chronic sinusitis, and in patients who have ciliary abnormality, men and to some extent women will be infertile because the cilia share the same structural abnormality as sperm tails and to some extent the oviduct. And physical findings, crackle, localized crackles, rhonchi, those low-pitched wheezes, lots of noises, pops and squeaks and crackles that don't go away. They're chronic finding of bronchiectasis. Some patients with widespread bronchiectasis will have clumping, just like the children with cystic fibrosis. And just as in our patient, they have a characteristic bacterial flora, just as we learned for cystic fibrosis. The non-CF patients will grow with bronchiectasis will grow staph, Haemophilus, and sometimes other gram-negatives like Pseudomonas. I think Pseudomonas is sort of a red flag in the outpatient setting. And the patient who doesn't have a trait, wasn't just in the ICU, it's probably bronchiectasis. Sometimes they have non-bacterial flora, mycobacteria, or fungi infecting these bronchiectatic airways. Imaging, here's an x-ray. This is a patient we were asked to see being evaluated, truth be told, for infertility. We went to see that admitting diagnosis was pneumonia. She said, my x-ray always looks like this. That's what the doctor always says, pneumonia. And here it is, right middle lobe, perhaps lingula, easily seen on the lateral overlying the heart. Minor, here the major fissure has been pulled up. Maybe the minor fissure pulled down because there's often volume loss associated with bronchiectasis. But the definitive diagnosis, as you know, is CAT scan. And CAT scan is both sensitive and specific for the diagnosis of bronchiectasis. And here are the features that we'll look for. The bronchi that don't taper, that remain dilated even as you go towards the periphery. Comparing the diameter of the vessel that runs together with the bronchus. The usual is that the internal diameter of the bronchus is the same as the diameter of the vessel that it runs through. And so if the diameter of the bronchus is 1.5 or more times the diameter of the accompanying vessel, then you can say it is dilated. And so that's abnormal. Dilatation is a feature of bronchiectasis. If you can see the bronchi way out there in the periphery where you don't usually, within a centimeter of flora, that's a dilated bronchus. And then we'll look for thickening of the wall due to chronic inflammation. Here's an example. Thickened bronchus, big, dilated, much bigger than the adjacent blood vessel, the internal diameter, a lot of airway wall inflammation. And I show this one because people looked at this and said, oh, I could put my finger in here. This would be a ring, a signet ring appearance of bronchiectasis with the bronchus cut in cross section. This is one of my favorites, a dramatic left lower lobe bronchiectasis with big dilated airway branching way out to the lung periphery. That's easy to diagnose. And then this image I like because it shows what happens when these dilated airways filled with air become filled with mucus, so-called mucoid impaction. It has the exact same shape as here. This is the same patient on two different occasions, but now mucus filled is a white branching tube, bronchiectasis with mucoid impaction. What causes bronchiectasis? Could have been that bad pneumonia that never got adequately treated, or severe necrotizing infection. Occasionally a benign lesion sits there long enough as a focal obstruction, and then there's distal bronchiectasis. But if it's not a localized area, it's more widespread, we're going to think of an underlying predisposition, maybe cystic fibrosis. We can test for that with sweat chloride or genetic blood testing. Primary ciliary dyskinesia, we can test for that with nasal biopsy, sperm tail analysis, or now genetic testing as well. Hypogammaglobulinemia would predispose to recurrent chest infections, measurable serum IgG, and alpha-1 antitrypsin deficiency, usually associated with primarily emphysema, probably also bronchiectasis. Again, measure the alpha-1 antitrypsin level. In the days prior to highly effective therapies, AIDS and recurrent chest infections led to bronchiectasis. Occasionally, immune diseases, collagen vascular diseases like rheumatoid are associated with bronchiectasis as an extra-articular manifestation, so too ulcerative colitis. Bronchiolitis can progress to bronchiectasis. And then two that I like to highlight: one, non-tuberculous mycobacterial infection, Lady Windermere syndrome, mycobacterial infection, particularly in postmenopausal thin women, leading to bronchiectasis. I think that the mycobacteria causes bronchiectasis. And then allergic bronchopulmonary aspergillosis. Remember, this is the asthmatic patient who has colonization, particularly of the central airways, leading to this whopping immune response that brings in the eosinophils and other inflammatory cells that lead them to bronchiectasis. Let's just look at the two images of first non-tuberculous mycobacterial infection, bronchiectasis. Typically middle lobe and lingula would be very common, dilated small airways, and tree in bud nodules, little tiny nodules surrounding small peripheral vessels. Tree in bud nodules, bronchiectasis in the periphery, particularly middle lobe and lingula, might make you think about this diagnosis. And here again, a dramatic pathognomonic, I think, image: central bronchiectasis, big dilated areas, not airways, not in the periphery, but here centrally. This would be very characteristic of allergic bronchopulmonary aspergillosis. For those taking the boards, I put in some of the unusual causes of bronchiectasis: tracheobronchomegaly, yellow nails syndrome. No, it wasn't my cigarette smoking that made my nails all yellow. It's associated with lymphatic hypoplasia, pleural effusion, and bronchiectasis. Young syndrome, which overlaps with cystic fibrosis and its association with azoospermia, and this genetic disorder, Williams-Campbell syndrome, with bronchial cartilage deficiency. So what's our treatment for these patients with bronchiectasis? It's antibiotics, periodically to treat infections, sometimes chronic suppressive antibiotics when the symptoms are dramatic and require regular therapy. And then the other part is clearance of secretions. Cough up and clear out that phlegm so it's not a fertilizer for more bacterial growth, and so that it doesn't block the airways and compromise your lung function. So get that sputum out will help with bronchodilators. We would help with mucolytics if we had effective mucolytics. They work for cystic fibrosis like hypertonic saline and DNase, but I'm not so sure in non-CF bronchiectasis. And then these various vibration techniques, the flutter valve or the vest or whatever, just to help loosen the secretions and promote their clearance. Loosen in the sense of knock them off the walls of the bronchi so that they are more easily expectorated with a cough. And then for some patients, we'll look at the chronic suppressive anti-inflammatory effects of azithromycin. I think corticosteroids are controversial, help suppress inflammation, help impair defense against bacteria. What's of interest in bronchiectasis is the use of inhaled antibiotics for chronic symptomatic disease. This was studied in cystic fibrosis initially, but was true for non-CF bronchiectasis as well, delivering medications that aren't available orally in high doses to the airways where the infection is. Here they gave tobramycin 300 milligrams by nebulizer twice a day versus placebo. They did every other month, try it 1 month on, 1 month off, hoping to forestall the emergence of resistant pathogens, resistant Pseudomonas. And they monitored lung function, the density of Pseudomonas, and the need for the frequency of exacerbations. And lung function, here's a month on, a month off, a month on, a month off, improved with the tobramycin over 6 months, did not change with placebo. And exacerbations were fewer, hospitalizations were fewer. And this has become common therapy: nebulized antibiotics, tobramycin, aztreonam, and colamycin are the ones commonly used. And then for those with multiple exacerbations over the course of the year, could we reduce the frequency with anti-inflammatory antibiotic use of azithromycin? This study use 500 milligrams 3 days a week, another 250 every day. And here you can see the frequency. Here's the placebo group in terms of a number of exacerbations, a greater number free of exacerbations in the azithromycin treated group, an option for those with multiple flares on antibiotics again and again. We talked about bronchodilators, clearance, trying to vibrate the chest. It used to be clapping on the back and postural drainage. It's labor intensive, and so these alternatives. And it is true, you'll hear your patients say, you know, if I go for a run, if I walk on the treadmill, if I go for a swim, that helps me to clear the secretions. Okay, and then finally, complications. We talked about hemoptysis, the emergence of resistant organisms, as you can imagine, in those who are on multiple or prolonged courses of antibiotics, and loss of lung function leading to respiratory failure. And this leads us to our last topic, bronchiolitis, the other obstructive lung disease, focusing on small airway obstruction. And you're certainly familiar with acute bronchiolitis, particularly in children, right? Viral or mycoplasma induced. But chronic airflow obstruction from chronic cellular inflammation of the bronchioles can be a follicular, as seen in collagen vascular disease, can be mineral dust bronchiolitis in the coal miner, can be respiratory smoke, cigarette smoke respiratory bronchiolitis, the early manifestation of lung pathology in cigarette smokers, airway pathology. And in Japan, they see what seems to be an infectious diffuse panbronchiolitis treated with macrolide antibiotic. But we're going to talk about bronchiolitis obliterans, or that again, chronic and doesn't fall into any of these categories. The pathology is small airway inflammation, and then sometimes seeing this characteristic polypoid protuberance into the airways, compromising the lumen and helping to make the diagnosis. And in very severe disease, you're sort of obliterated most of these airways. So what causes bronchiolitis obliterans? Remember the silo fillers lung disease in medical school? The farmer, before they knew it, opening the top of the silo and exposed to these green fumes that had nitrogen oxides that inhaled would cause an ARDS picture and small airway inflammation, reflecting where the gases are depositing. More recently, you may have seen popcorn, butter flavoring workers, those who are preparing the artificial flavoring, are exposed to diacetyl, and other workers may have the same exposure. This chemical depositing on small airways, eliciting a bronchiolitis. Occasionally viral or post-viral bronchiolitis, and then don't forget occasionally immune-mediated, again, rheumatoid arthritis and unexplained airflow obstruction. It isn't asthma, never smoked cigarettes, or alpha-1 antitrypsin deficiency. Could be bronchiolitis obliterans associated with rheumatoid arthritis or ulcerative colitis. And if your institution does transplantation, bone marrow and lung, you'll see quite a bit of obliterative bronchiolitis as part of graft versus host disease in bone marrow transplant, and in part of chronic rejection in lung transplant. So the symptoms, kind of non-specific, short of breath, often a non-productive cough. You may hear some crackles. You may notice hyperinflation of the lungs. A characteristic mid-inspiratory squeak has been described, but isn't typical. And they may just have some expiratory wheezes, and you're thinking, gosh, bad obstructive lung disease, but not asthma, not COPD. What could it be? X-ray, typically hyperinflated, maybe some patchy opacity. CT, this area, idea of relative oligemia, poor perfusion in certain areas, giving this mosaic, patchy appearance, mosaic oligemia. I just wanted to show one patient I saw, a horrible story, a woman trapped in a house fire finally pulled out after this toxic smoke exposure in our ICU, intubated ARDS phase, from which she recovered, but went on to develop, these are old films, developed hyperinflation, cleared out the opacities, but the lungs kept getting bigger and bigger, and few lung markings from this bronchiolitis obliterans that she developed and ultimately succumbed to. This was post-toxic gas inhalation injury. Our treatments, sadly, are limited. We have anti-inflammatory steroids that work not so well. We give oxygen, of course. Post-transplantation, people have tried other things for post-transplant bronchiolitis obliterans, including taking the lymphocytes out of the body, exposing them to light and reinfusing them, or sometimes the TNF alpha blocker, the etanercept plus montelukast plus fluticasone, and other experimental therapies that are in process of being evaluated. But sadly, bronchiolitis obliterans remains often very refractory to our therapy. And so those are the subjects that I thought appropriate to talk about. They might not be covered elsewhere in our program. And thanks for the opportunity to discuss them with you this morning.